Welcome to this first meeting of our Periscope group. I should just introduce myself briefly, first of all. My name is George Griffin. I'm a clinical biomedical scientist and was Professor of Medicine at St. George's Medical School in London until recently, and was also the President of the Federation of European Academies of Medicine until a few months ago, when I became a Vice President after my 3-year term, and was part of the team that put together this very, very extensive grant towards the Periscope initiative. Next slide, please, Laura. Next slide, Laura. Thank you. Now, just to update you to make sure we are all on the same framework, this was part of Horizon 2020 and was part of the coronavirus global response. It's a massive grant, 10 million euros with 32 partners, started in November last year and will finish in October 23. And you will see there the 4 overarching goals. First of all, to look at the impacts of COVID, then to develop solutions for policymakers, how to mitigate the effects of this outbreak, but perhaps more important, to look at the future and how we can build so that we are not taken so unawares as we have been this time with COVID. Next slide, please, Laura. The particular section that we are involved in is mental health and health inequalities. And I can tell you, in my work as a physician at St. George's Hospital in London, 1,200 beds in quite a poor area of the town, there are still, even in London, health inequalities. There is no doubt about that. A large immigrant population, and now, of course, we have throughout Europe the challenges of the refugee influx because of the problems in the East. So really, this is a very, very important piece of work that we will be undertaking. And there are 3 aspects of the methodology that you'll see at the bottom there with the bullet points. First of all, a major literature review, which is already in progress in the FEAM office. Then, as part of that, to identify lacks in data and gaps and inconsistencies in policy. And particularly, and this is the first of our workshops, of course, it's to gain guidance from a multidisciplinary scientific committee. And I welcome you all to that, because you are all experts in various aspects of this endeavor for Periscope. Next slide, please, Laura. And these are the partners that you'll see for this part of the study, from France, the UK, Sweden, and Belgium. And you will see there the particular aspects that each of those will be looking at. Homeless populations from France, race and ethnicity in COVID from the UK, mental health inequalities, and particularly looking at the elderly. But we do know, of course, that children have been severely affected by this. And then from Belgium, from those 3 groups, the migrants and refugees that I've spoken about briefly, and then again, mental health and policy. And the FEAM office itself, and Laura and Emma and Patrick and Ruben, they are part of this conference today, and they will be helping us with both the logistics and have been very, very helpful in getting all this together. Next slide, please, Laura. So this is the program that you all have. I have finished my my introduction now, other than just to emphasize it's a great pleasure to me to be part of this and to see you as experts in the areas that I've mentioned. So we move on straight away then now to the actual program of the science, and we move on to the first talk, which is from Giuseppe, a distinguished professor in Turin, and he's going to talk about assessing the impacts and learning from the pandemic in terms of health inequalities, to set the scene. Giuseppe.
Thank you, George. I'm trying to share my screen now, and thank you for this invitation. In fact, while the pandemic was landing in our society, we as Italy, we were coordinating a new joint action on health equity in Europe called JAI, where 24 ministries of health were trying to improve their capacity in policy response to health inequalities. While we were doing this important effort with more than 80 actions, concrete actions of innovation in policy response, the corona landed, and we had also to deal with this issue that your project is trying to solve, of assessing the impact and learning from the pandemic in terms of health inequalities. And in fact, our first point was that in the common sense, the main idea was that the COVID was a democratic nature and was also perceived as universal, the distance measures that were proposed. And so this was the main narrative at the very beginning of the pandemic. But if you look at the literature on influenza pandemic and socioeconomic status, there was a clear association between socioeconomic status and the previous pandemics. So this was a good reason for trying to understand how to do an health inequalities impact assessment and to develop a tool for an health inequalities impact assessment. And we started since the first months of the pandemic as joint action to elaborate, to work on a conceptual framework that was able to organize the set of plausible mechanisms through which the pandemic could influence the different social distribution of health. And in fact, some tools, some screening tools for this activity were already available in the literature. And we tried to develop further these tools in order to move from an effort of health inequalities impact assessment to a more important effort of health equity audit, which is a process, which is not a screening of the mechanism, but is also a process of recalibration of policies that could be more favorable for an equitable distribution of the impact, involving both the how to make less unequal the resurgence in the next waves, how to make equal the testing, tracing, the treatment, how to avoid unequal foregone care, and how to limit the unintended social and economic consequences of the pandemic. So in the next few slides, I will show very quickly this checklist of mechanisms that we proposed and used. I will not go into details of specific categories of mechanisms that I will show. You will have the opportunity to read the detail yourself. But there were some direct mechanisms of COVID that were about the unequal exposure to risk of infections, like lower adherence to the hygienic and behavioral norms, or less space for distances in overcrowded houses, or segregation in deprived areas with more contacts, or segregation in occupation that were not eligible for smart working, segregation in nursing homes. So these are the only example that I'm reading now of the specific mechanism that were included in this checklist as for the category of differential exposure to risk of infection. The same was elaborated for differential health vulnerability to COVID-19, given that the exposure was equal or unequal, that was the mechanism of health vulnerability. How was unequal the exposure to barriers in access and use of good quality healthcare to COVID-19? And then there were also some unequal impact in the health sector that were related to differential impact of displacement of non-COVID-19 care. That were another important set of mechanisms creating health inequalities, like also the differential impact of less demand and of health and social care, so on the size of demand caused by different perception of risk and anxiety caused by the pandemic. And then we move to the indirect effect out of the health sector. And this was the unequal impact on health expected due to the lockdown on social determinants, the unequal impact on social determinants of health, like employment, income, debt, and so on, or differential capacities to face challenges and opportunities coming from isolations, and or differential impact of opportunity for education due to school closure, lockdown, and or differential impact of the lockdown at the community level, so in the networks and the social networking, or still a differential impact of lockdown of low social care, social assistance, and finally differential impact on downward social mobility due to the experience of disease during the pandemic. This was the checklist that we developed for and proposed to our partners in the joint action. And we also share this checklist with other colleagues, for instance, with the Institute of Health Equity in London. And in fact, they were the first to publish a comprehensive review of the health inequality impact in England, committed by the Health Foundation, that is a charity. At the same time, a few months later, also the Italian Ministry of Health committed an Italian review of the impact. And if you look at the outline, of course, we will not go in details, but the outline of this report that has been reported to the Ministry of Health in May and is under consideration is exactly asking the same question for each mechanism that we were presenting before. I will show you a few examples of this Italian report just to see which kind of evidence is available for answering to these questions. And this is the case of the natural history of the COVID disease. This is the example of a region, 4 million people, the Piedmont Northwest region. Many other regions are doing the same. In this case, I will show you the inequalities in COVID-19 and infection and mortality, and just after the inequalities in healthcare access that are the direct mechanism of COVID-19 pandemic, and then we will move to the final conclusion of this review. For instance, we classified our population by the number of social disadvantages. These are the adults, male and female adults under 65 and the over 65, classified for having 0 social disadvantages, 1, 2, or 3, or 4. And the table is showing the relative risk of being tested, of being infected, and then of dying. And this is the relative risk, the relative index of inequality that is summarizing across the number of disadvantages, the level of inequalities. As you can see, what we can comment is that there is a good correspondence between access to test and positivity rate in elderly and adult women, with relevant inequalities, increasing the number of social disadvantages, the risk of infection almost double. The only exception are the adult men, where probably the fact that this group was allowed to continue to work in industry where they were very well tested as given more opportunity to level up the probability of the risk and also the control that were available in the industries in this case. As for mortality inequalities arise if we move to these severe outcomes in all the groups, as you can see, both in the adult men and in the adult women and in the elderly, there is a very strong inequalities that is corresponding to inequalities in positive rate. Large inequalities, significant inequalities in infection with significant inequalities in mortality. If we move at equity in healthcare, given that we have reported here the inequalities in infection, you can see the inequalities in hospitalization, where you can see that there are emerging growing inequalities among adult men and women. And the same is and in this case, if you go to control to adjust for comorbidity, you see that this kind of inequalities just decrease of 1/3, 1/4. It means that inequalities in morbosity, in comorbidity explain only 1/3 of the inequalities. If you move at the intensive care, inequalities are even there, but a bit less among the elderly. It means the access to intensive care is relatively more frequent among working age people, probably by selection for age and by severity of the diseases, while increasing inequalities emerge among adults and especially women. They disappear among older people. So our worry was where the elderly people discriminated, given that the more disadvantages had a higher infection and higher hospitalization, why they have not been transferred to intensive care with the same rate. So we looked at the probability of being moved to the intensive care by social inequalities, by social disadvantages, and there were no inequalities in the probability of going to moving to intensive care, and at the same time there were no inequalities in mortality within the hospital admission. Broadly speaking, inpatient care was equal. This is just to show you the kind of evidence that was available, and the main conclusion was that the corona landed on an unequal epidemic of chronic diseases, and this is the main problem at the beginning. Unequal epidemic of diabetes, of obesity, of chronic respiratory disease, and so on. And this is able to explain about 1/3, more than 1/3 of inequalities in mortality, for instance. But at the same time, on this baseline of unequal epidemic of chronic disease predisposing to corona diseases, we had also a small impact of unequal infection and equal access to test. And then moving to inpatient pathway of care, this pathway of care was inpatient, was proportional to the need, so its contribution to inequalities was very low, while it was much more important the unequal outpatient pathway of care in terms of large widening health inequalities. And finally, a very strong inequality in mortality. What about the unequal recovery from displacement of non-COVID care? This is another example of that I will show the kind of evidence important. Let's keep the the knee prosthesis surgery by education during the first wave of the epidemic in 3 regions, Piedmont, Emilia-Romagna, and Puglia. The first relative index of inequalities is before the pandemic, and then the second for each region is during the pandemic. As you can see, there were more use, so because of higher needs among the less educated before pandemic of this kind of surgery, but the same need remains, while less use among the less educated in the pandemic were happening, as you can see. So this is a clear demonstration of a discrimination in recovering from the displacement of care. And then there are many other mechanisms that have been documented in the review: an unequal trap for the poverty, unequal risk of unemployment, unequal risk of loss of educational opportunity, unequal risk of isolation, and unequal risk of access to voluntary and social care and services. So this was the main conclusion of our review, and the size of the arrow are also saying how much important were these mechanisms. And if you try to classify this mechanism according to as an entry point of policies, you can see that the red mechanism are just suggesting out which could be the measure of the social impact of the pandemic. This yellow was related to how to recalibrate the prevention and care of chronic disease in a more equal way, in order to afford this impact, this unequal impact. The green one were related to the making more equal the preparedness plans for prevention in pandemics. The blue one was more equal requirements for preparedness in health system during the pandemic, and the gray one were more equal preparedness in social determinants of health policies. So these were the main conclusions, and these conclusions and recommendations were classified according to the relevance, the importance, and the observability, because not everything was clearly observable. So we suggested to the Ministry of Health which were the priorities for the policy tackling health inequalities in this side, and for priority for research, because less observable, but probably more important. There were also some specific little evidence, more evidence, but little importance, like in specific small vulnerable groups. And then we were asking if we were forgetting something of importance, some invisible need. In fact, we added another intervention. We joined this network from Lancaster University, which is the COVID-19, the other front line, that is exactly trying to give voice to those who bore the brunt of poverty and inequalities, to tell their stories. And we joined this network with a group of journalists and bloggers drawn from the groups and community already hardest hit, and working with the specific organization working with this group. And we documented how the pandemic is changing life of people and communities with stories of risk, solidarity, and resistance. There are 15 stories now in the website. And you can see this is the example of two Turing stories from Piedmont. One is from an African student during COVID-19, and the other are what children think. Well, this is the end of my presentation. I just finish with what we ask our partners in JAIN, the joint action with a survey that was submitted to the 24 European countries just during at the beginning of the second wave. And we were asking which were the inequalities, if there were any inequalities related to impact, inequalities of non-COVID impact, the displacement of care, inequalities due to direct mental health impact of social distances measuring, and current and future policy inequalities because of social determinants of health. And for each of these entry points, we try to understand if this entry point, this mechanism suggested by our checklist were put into the political agenda, if mitigation policies have been implemented, and whether the Ministry of Health has been taken the lead of this process, and finally, if there were good data for this purpose. These are the main conclusions. I will just show you the score from 0 to 100 on these questions that we pose, the kind of if the inequality has been put into the agenda, either the one of the healthcare impact of COVID or non-COVID, displacement of care, of lockdown impact and socio-economic consequences. And if you see, no country has given no attention to equity, the fact that the pandemic far from being equal, and the differential impact on population is shared and recognized political apprehension, and awareness is being followed by actions to tackle unequal impact, but there is no evaluation on effectiveness, but many measures have been taken, in particular to mitigate the impact on vulnerable groups, and ministries of health have been directly involved and leading this process. This is quite expected from action in directly tackling the unfair impact of the disease and the reorganization of healthcare, but it seems also relevant from other points of view. And finally, data availability has been less encouraging during the first epidemic, but meanwhile, new analyses have been realized, but still require some time to collect the needed data. So this is the final horizon of description of the horizon of activities that have been undertaken under this joint action, and maybe may help you to frame your project with this anticipation of results from GE. Thank you. George, you're mute.
Yes.
Thank you, Giuseppe. I can see why you are called a distinguished professor, and that was very clear. And your data are really, really good and important. And I think it's a great credit to the Italian healthcare system that the most disadvantaged groups had very similar mortality in the end to the advantaged groups. It's a credit to show equality of care in that acute situation. But of course, the other side was the challenge with the community care, which clearly was still unequal. But those data are very, very important and a great start to our talks today and to Periscope. So thank you very much. Thank you. So there was just one question, and we have a minute or two from Mark Lawler. Have you looked at the susceptibility using other clinical parameters, such as patients with cancer or obesity? And are there big differences there? We see obesity, of course, being a big determinant in the UK.
Yes, I have shown you the fact that the relative risk just decreased of 1/4 or 1/3 when adjusting by comorbidity that included metabolic diseases, obesity, and cancer, respiratory chronic diseases, and cerebrovascular diseases, and so on. So it's though not perfectly classified, I think that at least 1/3 of inequalities is related to the unequal epidemic of the chronic diseases that are the cause of susceptibility to the COVID, to the severe COVID. So 1/3 of these inequalities could be accounted, could be responsible for this to this susceptibility mechanism.
Yeah. Well, your data are very, very important. Thank you very much, Giuseppe, for a great start. So we move on now to a little bit more of the nuts and bolts of Periscope, and Emma Martinez, who is a senior scientific officer in FEAM, Federation of European Academies of Medicine. She's going to tell us about the work she's been doing to review the literature on health inequalities. Emma.
Thank you very much, George. So I'm going to present today the work that we did in FEAM on the rapid literature on the socio-economic, on the health inequalities impact. And can we please? Yeah. So this is a work that FEAM conducted as part of the Periscope project, Work Package 2, and it was a scoping literature review focusing on the impacts of COVID-19 on health inequalities. The question we were trying to address with this review was whether the pandemic was having an unequal impact in different individuals or groups in Europe according to socio-economic status and race and ethnicity. Next, please. So what we were hoping to address with this review is to help explain the wider impacts of COVID-19 on vulnerable populations, which is one key topic of this work package, and to help uncover potential gaps and obstacles in the collection of data on COVID-19 and health inequalities. In order to perform this literature review, we conducted a search in PubMed using the terms socioeconomic determinants, socio-economic inequalities, health inequalities, health inequities, inequities, race or ethnicity, together with COVID-19 or SARS-CoV-2 and Europe. We included in the search all languages and publication types and articles published from 2000 until 15th of May, 2021. The search rendered 485 articles in total. And then these articles were screened by 2 reviewers against the PICO criteria, which stands for Population, Intervention, Comparator, and Outcomes. Given the population was all people of any age with a presumptive or confirmed diagnosis of COVID-19, the intervention being the social determinants of health, particularly race and ethnicity, income, educational level, employment status, and working conditions. And the outcomes analyzed or included were COVID-19 infection incidence, whether confirmed or presumptive diagnosis, acute severe adverse events, particularly mortality, incidence of acute respiratory distress syndrome, incidence of multiple organ dysfunction syndrome, incidence of opportunistic infections or cardiovascular events, and long COVID. Other outcomes included in the screen were healthcare utilization, particularly hospitalization, intensive care unit admission, length of stay and use of and length of time on supplemental oxygen therapy or mechanical ventilation. And we excluded from this screen mental health outcomes, as this has been dealt by another part of the work package. So the screen rendered 85 articles and 7 other articles were included suggested by experts. So we had a total of 92 articles included in this rapid literature review. So from the findings, we found 26 articles were reported on events on European countries, 64 were coming from the UK, and 2 of those studies reported at the international level. So the European studies, 8 of them came from Western Europe, 9 came from Southern Europe, 3 were from Sweden, 2 from Germany, and 1 from Switzerland. And the majority of those studies reported findings at the regional or sub-regional level rather than the national one. And in terms of study designs, we found a diverse study designs in the studies coming from the UK, including cohort studies, surveys, and observational studies, while the articles on European countries were more observational and ecological studies. We found a comparable volume of research on socioeconomic determinants and COVID-19 outcomes between the UK and the European countries. However, there was a stark difference when reporting on race and ethnicity and COVID-19 outcomes. The social economic determinants most reported about were gender and deprivation index, mainly from those studies from the UK, and the workforce status, both in studies from the UK and from in European countries. Those socioeconomic determinants not reported about in studies coming from European countries, but reported about in UK studies were household size, comorbidities, and population density. And alternatively, so those socioeconomic determinants not reported in UK studies, but reported in studies coming from Europe were age, occupation, and income. And I put an asterisk there because it might be that income in the case of UK studies might be included in the deprivation index, which is a more encompassing indicator of wealth. So from the analyzed outcomes were COVID-19 incidence, admission to hospital, and mortality. And there we saw that most studies reported worse COVID-19 outcomes for ethnic minority groups and groups with low social economic status. And 3 studies reported no relationship between either of these 2 variables and COVID-19 outcomes. Oh, yeah, there was a conclusion slide that I made this morning. I don't know whether I can, no, it's not there, Lord. I don't know whether I can share my screen. Thank you. Let me share my last screen. So as conclusions, we found limited numbers of studies coming from countries in mainland Europe, so excluding the UK. There were very few nationwide studies available in countries in Europe, so most of them reporting at the regional or sub-regional level. And there was a lack of common terminology referring to ethnicity. So for example, the term BAME, Black and minority ethnic groups, is a term that is used often in UK literature, but is absent in papers coming from Europe. And then there was a lack of consistent approach for gathering data on socioeconomic status and race and ethnicity. So those are the gaps that we identified, some of the gaps we identified in the literature review. That was it from my side. Thank you.
Good, thank you. Thank you very much, Emma. That really joins very well with Giuseppe's talk, but it shows that there's an inconsistency across Europe in terms of definitions and so on. And that's something we may talk about later on. Can I encourage everyone to look at the chats? Mark again raised a very interesting question about vaccination and health inequality, and Giuseppe gave a very nice answer and says they're looking at it at the moment. But I suspect there will be a considerable difference there. But I look forward to those data, Giuseppe, when you get them. So let's move on then to our next presentation. This is from Ilse and Eva from Ghent, from the University of Ghent in the Netherlands. Impacts on vulnerable populations, migrants and refugees, results from the Apart Together study.
Hi, good morning, everyone. We were part of the Netherlands a long time ago, but now we are in Belgium, in Ghent.
Right, okay.
So, welcome from Ghent in Belgium, where we speak Dutch. Yeah, that's fine. So welcome to everyone. Eva and me, we would like to introduce you very shortly to a large study that we did in the beginning of the pandemic in March 2020. We started with the Apart Together study, guided by a consortium of academics in Europe, and then picked up later on by the World Health Organization to scale it up to a global survey, looking at the impact of COVID on the psychosocial well-being of, in particular, refugees and migrants, because that group, despite the fact that there has been quite some pandemics over the years, SARS, Zika, there has been quite some, there's very little known about the specific impact on those groups of refugees and migrants. And that is why from Ghent, together with that academic consortium, and then later picked up by the World Health Organization, we started to conduct an online survey on psychosocial well-being of refugees and migrants. We will or Eva will present some findings out of this study. Of course, there's many more. We will also put the references of articles that coming up slightly for the moment in the chat. So if you want to get a bit of a deeper insight in some of the findings, you can have a look at those publications. But I also want to stress that next to the quantitative survey, of which we will present some main findings today, we also did some qualitative research. So in-depth interviews with refugees and migrants in different groups, so undocumented migrants, young migrants, so in different groups, particular vulnerable situations, and which can, I think, largely complement and to a certain extent also explain the findings of the quantitative survey. This is as a very small introduction of myself, and I give the word to Eva.
Hello, everyone. My name is Eva Spiritus Beerde. I am a PhD student, and Ilse is my promoter. As she said, we work on the Apart Together project, where we focus on assessing the psychosocial impact of COVID-19 on refugees and migrants across the world. And we saw that there is a very important research gap when it comes to this, and we wanted to focus on refugees and migrants specifically because we know that their lives are already have numerous stressors such as discrimination, poor living conditions, and psychological distress. And this makes them especially vulnerable during the pandemic, as healthcare services and protective services are often overwhelmed and undercapacitated. So we wanted to focus on that. Our survey was distributed in 37 languages with self-reported questions. As Ilse said, we have quantitative and qualitative data because we have also some interviews that we can later use to complement these analyses. We collected data from around the world between April 2020 and November 2020, and at the end we reached over 30,000 respondents. The survey focused on 5 different categories, which you can see here. So we asked about the socio-demographic characteristics, the COVID-19 health and behavior, respondents' daily stressors, their mental health, and their social well-being. As you can see here, the first descriptive analysis of the survey showed that 55.5% of the respondents were male and 44.4% were female. You can also see that the majority of the respondents live in a house or apartment. This is likely due to the online nature of the survey, but we think that a group of respondents between 300 and 600 in the other groups is still valuable to do a further analysis. So first, I want to focus on the pandemic behavior of refugees and migrants in our survey. We asked about whether they would seek healthcare in case of suspected symptoms or a suspected infection. And we saw that respondents that were less likely to do so were those that don't have documents, those that live on the streets or in insecure accommodations, those that live in the African region, and those without schooling. But overall, we saw that only 5% would not seek healthcare in case of suspected symptoms. And the reason for this is most likely their lack of financial means or their fear of deportation. When we asked about the sources of information they use to gather information on COVID-19, we saw the same tendencies for all age groups, where most likely news from the country they live in and social media was used. Respondents that indicated that they don't understand or trust the information that they receive, we saw that they were likely lower educated, also live on the street or in insecure accommodations, or did not have any residence documents. Looking at the respondents' mental health items of the survey, we can see that the majority of the respondents reported a deterioration of their mental health on almost all items, especially regarding feelings of depression, worries, anxiety, and loneliness. Also, 1 out of 4 respondents indicated that they used more substances than before the pandemic. Overall, we saw that that women were more likely than men to report worse mental health, and also older respondents compared to those that were younger than 20. And respondents that lost their job or were sent home without pay were also more likely to indicate a worse mental health since the start of the pandemic. When focusing on the social well-being of respondents, we saw that on average, respondents indicated or rated their social isolation on 7 on a scale from 1 not at all to 10 extremely, which is quite high. And when asking about the loss of connectedness, we see that respondents that live in asylum centers or on the streets or in insecure accommodations rated this worse than before compared to those living in a house or apartment. And the loss of connectedness was also much worse for people with no documents or permanent documents. Further, we also asked about the experiences of discrimination.
Oh, sorry.
The experiences of discrimination, where we saw that between 13 and 27% of the respondents indicated that this was worse than before. And here again, we saw that there are some risk groups, and namely respondents between the ages of 20 and 30, respondents that live on the streets or in insecure accommodations. And this is especially the case for respondents in the African region, and also respondents that are unemployed or without residence documents indicated their experiences of discrimination to be worse than before. In a recent study, we went a little further than only the descriptive analysis by looking at the role of daily stressors, such as NGO support, access to food, access to healthcare, and perceived discrimination and their impact on the mental health of refugees and migrants. Since no standardized questionnaire was used, we had to do some exploratory and confirmatory analysis, where we found 2 factors for mental health, which the first one we called anxiety and depression, including items such as anxiety, depression, and worries. And the other one is hyperarousal, including substance use, anger, sleep problems, etc. And we saw that, that there was a significant effect of age, gender, residence status, housing situation, all 3 daily needs, and also discrimination on the mental health of refugees and migrants. So again, respondents that live in more precarious situations, such as insecure residence statuses, insecure housing situations, those that have their basic needs or medical needs less fulfilled, or respondents that experience more discrimination, are also more likely to experience a worse mental health compared to the other groups. So to wrap it all up, we see that there are some groups that are increasingly at risk. These are respondents or migrants and refugees without documents, migrants and refugees living on the streets or in insecure accommodations, those that live in asylum centers or in refugee camps, and migrants and refugees living in the African region. We also saw that 22% of the refugees and migrants reported that discrimination based on their origin has worsened since before the pandemic, which we later saw that it was detrimental for their mental health as well. Over 50% of the respondents report access to work, safety, and financial means, which are daily stressors in our survey, to be worse than before the COVID-19 pandemic, which we later also saw that was detrimental for respondents' mental health. And finally, we saw that 60% of the refugees and migrants in our survey report more feelings of depression and more worries since COVID-19, and also more than 50% report to feel more anxious and lonelier. So the first results of the global study already provide us with some very important information. The pandemic has had a detrimental effect on daily living conditions for all, But we saw that for certain groups of refugees and migrants, conditions have become increasingly difficult. Therefore, it is important to strive for equity when it comes to the COVID-19 policy responses by including the most vulnerable in the conversation. To protect refugees and migrants' human rights and rights to health, measures are needed to increase refugees and migrants' access to multi-language information and to health services, both medical and psychological. So this was a kind of the presentation. Thank you for your attention. And if there are any questions, Ilse and I would love to answer them.
Thank you. Thank you very much, Eva. We just have 1 minute actually, and I'd like to ask, did you have difficulty having access to these groups? How did you arrange that?
Well, what we try to do is make as much as possible contact with different organizations working with refugees and migrants. We announced the survey widely in different Facebook groups on social media and so on. But it's clear that the most, let's say, vulnerable populations are also the most difficult ones to reach, because they are illiterate in their own language, they don't have access to online means to complete the survey, or they just are not in the position or don't have the willingness to do so. So it is clear that if we would have found other ways of accessing people, we also worked in some regions with excuse me. We also worked in some regions with enumerators who passed by, but that is of course in the time of pandemic also not very easy because of the risk that is related to that. But if we would have had the possibility to go closer to, for example, refugee camps or people living in the streets, and then the results would be even more outspoken for those particular groups in very vulnerable conditions.
Thank you, Ilse. That's a really, really good explanation in a very, very difficult area. But nevertheless, the data that you've obtained are very much in parallel with those that Giuseppe was telling us about.
Absolutely. I think that the most, for me, one of the most striking and important findings is the increase of experiences of discrimination. I think that's a very, because we asked both questions, like to what extent do you suffer from discrimination, but also to what extent is it worse than before the pandemic, not only for discrimination, but also mental health. So I think that was for me, together with the fact that in general, their situation got worsened if they already had difficulties, for example, regarding income or housing, that really, I think is a very important finding also from a policy perspective, is that the discrimination that they already experienced, that is what we all know, still was much worse because of the pandemic, which is a bit, a very worrying finding in my understanding.
Yes, thank you, Ilse, and thank you for your references in the chat, just to mention it to people so they can see your written documentation. And again, sincere apologies for confusing Belgium and the Netherlands.
No, any problem.
But I do apologize.
No, it's fine.
So we move on now, and we continue in this vein, looking at very vulnerable populations, and we're looking now at homeless populations. And Simon from INSERM is going to tell us about the homeless populations and the ECHO study. Simon.
Thank you. Okay. Thank you for having this opportunity. So my name is Simon Ducarreau, and I'm a social epidemiologist from INSERM in Paris. I'm glad to have this opportunity to present a summary of our results on the ECHO2 study that we conducted with Maria Melchior. So this study focused on the perceptions and impact of the COVID-19 pandemic among disadvantaged populations living in shelters. Just to remind the context, Beginning of 2020, we knew very little on the impact of the pandemic on healthcare access and implementation of preventive measures in disadvantaged populations in France, including the homeless populations. At the time of the first lockdown in March in France last year, the government decided to shelter the homeless populations. And we've been called at that time with Maria to study the health and the impact of the pandemic on this population. Therefore, the aim of this study was to investigate the health status, perceptions, and practices towards the pandemic and related policy measures in homeless populations. The study was designed as a cross-sectional, multi-centric, mixed method study, having a quantitative epidemiology component, as well as a more qualitative exploration. It was conducting first during the first lockdown last year, and a second round was conducted earlier this year. Sampling frame consisted for both rounds of shelters, mainly in the Paris and Lyon metropolitan areas. But this year, we decided to add day centers to cover an even more disadvantaged population of homeless groups that are not sheltered, which was not feasible last year, unfortunately. The inclusion criteria were to be above 18 years of age and not having any cognitive disorders. For the epidemiologic component of the study, we developed questionnaires that were available either online or paper-based. Questionnaires were administered face-to-face by trained interviewers, and at any time of the survey, telephone interpreters were available in order to limit potential bias due to language. The qualitative interviews consisted of semi-structured interviews with the help of interview guides based on the literature, and the interviews were conducted by researchers in several Paris and Lyon centers. I will now present some of the main results from the last year's survey, as the results from this year are still being analyzed. So for the first round of the ECHO study, a population consisted of a bit more than 500 participants, mainly young men that did not have either their partners nor children living with them in the centers. Most of them, almost 90%, were born in another country than France, which will explain that we have some common results with the colleagues that presented just before us. The main countries of origin were in Africa, and 3/4 of our study sample did not have a residency permit. And finally, most of them did not have a job at that time. I will give some of the figures of the different themes that we've investigated, and if you're interested in more details, more insight, and more discussion, I've inserted a flashcard that will redirect you to the shared place with all the publications that we already have and those that are coming very soon. So one of the first things that we observed were high level of knowledge of COVID-19 symptoms in these populations, as well as high level of adherence to preventive and management measures such as testing and isolation. On the topic of vaccination, 40% of all participants declared to be hesitant. We will be having a deeper look on these results in the breakout sessions later on this morning. Now, on the topic of addictions, we observed high level of prevalence of substance use tobacco use, alcohol, and other drugs. Having a closer look at tobacco use, these elevated prevalences were associated in our study with being a man, not having a stable partner, being born in a European country other than France, having spent more than 5 years in France, not being medically insured, and having been exposed to assault during the lockdown. Now looking at mental health in our study sample, 1/3 of our participants reported symptoms of depression based on the PH-Q-9 scale. This depression was associated with being a woman, being single, having a chronic illness, and facing food insecurity. On the other side, we observed also reduced rates of depression in participants over 50 years of age. A quick insight on qualitative results that we conducted for the first round. So we conducted 26 interviews, semi-structured interviews. We led an inductive thematic analysis approach. And based on these interviews, we identified 4 major themes. The first one was the sudden learning of the lockdown implementation, which really reminded our participants violent or traumatic circumstances such as war or mourning. Then the accommodation during the lockdown, in our participants, we really observed conflicting visions. For some of them, it really was a relief to And finally, the lockdown was really reported by the participants as having a particular impact on their daily activities and perceived health. To conclude on very short presentation, on the perspectives. So as told, we have conducted earlier this year a second round where we had more than 500 participants phase. We have about 50 interviews. We are now conducting the analysis to cover the healthcare access, implementation of preventive measures, the vaccine hesitancy and practices, addictions, mental health, and health literacy. To thank our funders and the ECHO working group for this work, and I will be happy to answer any questions.
Thank you very much, Simon. Good to see that you have an ongoing study now looking at more detail. I think we have just a minute or two if anybody would like to ask a specific question. The things that stood out to me were depression, which was in parallel with the earlier Ghent study, Simon. Is there any treatment offered in those 3 cities you mentioned for this, or is this just an observation at the moment? Over.
So for what we've done, we've only conducted the survey on assessing the levels just we had this hypothesis that we would expect a high level of depression or symptoms. And so as researchers, our main objective was to raise awareness, to just put the fact on the table. But on the ethical side, if we were to observe particular risk of mental health during our interviews, we were in close touch with the shelter management team just to make sure that no harm is done. But that was to some extent, and it was very, very rarely the case.
Yeah, but it's very interesting that you have a parallel finding to the Ghent study. Did you see any suicide associated with depression?
In our study sample, in the PHQ-9 scale, there's thoughts of suicide. That is one question. And so some of the participants declared having these thoughts, but no actual suicide occurred, thank God, during the survey.
Good, thank you. Well, we should continue to move on now. Thank you very much, Simon, and we look forward to hearing of your second study now that you're following up. Thank you. We move on now to look at the socio-economic and ethnic inequalities in Europe, and what are the issues there and what are the gaps. And Maria, who is the research director from the French National Institute of Health and Medical Research, will present this. Maria.
Hello, good morning. I'm sorry, I've had to change computers because of connection issues, and I don't have a camera, but I'll try to set it up for the for this afternoon's. For the later session. Let me just share my slides. I hope you can see my screen now.
Yes, we can see it.
Okay.
We can see your screen.
Okay. Great. So what I'd like to do following the presentations earlier this morning is go back to a broader picture on what we now know about social and ethnic inequalities with regard to COVID-19. And so, of course, some of what I'll say will be redundant or consistent with what Giuseppe Costa already said this morning, but I'm glad to see that we're trying to carry the same messages through. So I'm a researcher in social epidemiology at the Pierre-Louis Institute of Epidemiology and Public Health at INSERM and Sorbonne Université in Paris. And of course, the first thing I wanted to do is just remind us where we're at with the epidemic right now. So these are data from yesterday, which of course may have changed. What I just wanted to point out is that, well, we know that COVID-19 has spread throughout the world. There are over 4 million deaths already, and some countries are in Europe. We feel like things are going back to normal, but of course, other parts of the world are still very severely hit by this epidemic, and we don't know when this will be over. And oftentimes, we do think that infectious diseases spread, well, maybe not evenly, but at least that there's some sort of a equal risk with regards to who will get infected and how people will get impacted. And as Giuseppe already said, we know that that's actually not the case, and that even in the case of infectious disease breakouts, there are huge socioeconomic inequalities that emerge. Just very briefly, you may have seen this paper, which I find very interesting in Science a couple of weeks ago, or maybe a month ago, which shows the extent of socioeconomic inequalities with regard to COVID-19 in Chile, which is a country which was actually pretty badly hit by the epidemic. And the paper is based mostly on administrative data and hospital data. And what it shows is that essentially in low socioeconomic status municipalities, so neighborhoods, people were less likely to get tested for COVID-19, but when they did, they were actually more likely to test, to be positive, and to be tested at a later stage because of testing delays. And they were also more likely to have higher levels of mortality. And again, I think this goes back to what Giuseppe was saying, that, well, maybe, I mean, there are inequalities at different stages of the disease, and also the way in which these inequalities unfold may actually be different in different countries. We actually have some data on this from France, so I just wanted to bring it up, and I'm sorry, the slides are partly in French, but I copied them from national reports. So what you see is that here in 2020, the Paris region and the eastern parts of France were mostly hit by the epidemic. And what was observed very early onwards was that in the Paris region, the neighborhoods that were most likely to have high mortality were those that are in the northeastern part of the city and which are the poorest and have the highest concentration of immigrants. And even in the city of Paris here, what you can see is that rates of hospitalization were not evenly spread across the city. So the western parts are more chic and elegant. This is where the Eiffel Tower is. They're also more elderly. So you would actually think that these are the parts of the city where people are at higher risk of severe COVID-19. But actually what the data show was that hospitalization rates were highest here in the areas that are poorest and have the highest concentration of immigrant groups. So, sorry, one thing that I want to highlight is that I think everyone was struck, and that's actually something that Michael Marmot reported on also in the Build Back Fair report, which Giuseppe mentioned earlier. So we may have expected socioeconomic inequalities with regard to COVID-19, at least people who work in social epidemiology and know that socioeconomic inequalities are wide and unfortunately spread to many different health outcomes. But I don't think that anyone really expected the extent of ethno-racial disparities that have been observed and which have now led to various publications. I'll show you some data, but I think what's also interesting is just the thinking that goes with the data and where people are at in terms of what this should tell us about the data that we need to actually monitor all types of inequalities and disparities with regard to COVID-19, but also other possible health outcomes. So first of all, what we know is that there's a meta-analysis that was already conducted showing that people who belong to ethno-racial minority groups, and I'm going to use this broad term for purpose, on purpose, because there are data mostly from the United States where racial categories are coded in a particular way, but also from European countries and among those, particularly the UK, where other categories are used. So I'll just use the broad ethno-racial, minority category term as an umbrella term, but of course we can discuss that later if you want. So anyway, what the data show is that essentially members of ethno-racial minority groups, and particularly Blacks and Hispanics in the United States, have been found to have higher levels of COVID-19 infection. People who identify as or belong to Black community groups have also higher levels of hospitalization once they're infected, and this is also partly the case for Hispanics. And then this is reflected in elevated mortality rates across different countries. In the UK, there are similar data which have also shown that the categorizations are finer than what I've just shown you. But what the data essentially show is that same thing. There's an elevated risk of COVID-19 mortality in members of minority groups. And in the UK, this is particularly the case of persons who are Black or Pakistani and Bangladeshi, so from Southeast Asia. And of course, one of the issues is that most of the data come from 2020. And as the epidemic unfolded last year or in 2021, these things may have slightly evolved. But still, these disparities are still observed. We also have some data on this from France. Now, in France, we don't collect data on people's minority status, but we do have in national statistics their country of origin, their country of birth. And so what national mortality statistics for 2020 showed was that among people who are from sub-Saharan Africa, rates of mortality have doubled pretty much during the course of the epidemic, and they're much higher than in other groups. And this is particularly the case, this is the second part of the slide, for people who were born in Africa, in sub-Saharan Africa, who also live in very dense communities and neighborhoods. Again, this is just data from the UK showing that one of the issues is that people who get tested positive for COVID-19 have much higher rates of severe cases and worse prognosis than people who do not belong to ethnic minority groups. And one of the ways why this may be the case is because while there are higher infection rates, which are not always detected by universal testing. So, sorry, they're not always detected because because there is no universal testing and people don't always have access to tests. So in France, one of the issues, for instance, and this is also the case in other countries, was that people who are immigrant and particularly of African descent were much more likely to work in jobs that are considered essential and that were particularly exposed to the risk of transmission of COVID-19 in the first phase of the epidemic, since they were allowed to work and circulated more than people who worked in jobs in which they could distance work. Another possible reason, which was already highlighted before, for why members of ethnic minority groups may be at higher risk of poor outcomes is because of higher levels of comorbidities. And this is something that has been illustrated in France with regard to obesity, for instance. We know that certain groups have higher levels. And we do not know whether vaccination is actually playing a role in decreasing inequalities right now. But what we do know is that there are very big, both social and ethnic disparities with regard to COVID-19 vaccine. So these are data that show the levels of vaccination across different ethnic groups. And what you can see here is that they're lower. So minority groups have a lower tendency to be vaccinated than majority groups. I'm not going to go through this because we don't have time anymore, but I do highly recommend this paper by Kati Kiredi et al., which was just published in the Journal of Epidemiology and Community Health, and which tries to summarize the macro and maybe more meso-level determinants which may actually lead to excess mortality in ethno-racial minority groups. And this starts from the definition of what ethnicity is and what it means to belong to an ethnic minority group in most societies, which, or at least in Europe and in the Western world, where structural racism and other types of power imbalances are still very much at work and still put people who are not in the majority population at various increased risks. We can also maybe later discuss the risks of actually collecting data on people's ethnic minority group, etc. But overall, the message that I wanted to convey, and which we actually wrote in an editorial with Jay Kaufman and other co-authors, is that, well, first of all, we know that racism exists even in the absence of data. And I just want to maybe finish with these words by James Baldwin, that maybe not everything that is faced can be changed, but nothing can be changed until it is faced. And I hope that this epidemic will strengthen the belief that we do need good data on ethno-racial disparities with regard to various outcomes. Thank you very much.
Thank you very much, Maria. Isn't it interesting that there are consistent themes evolving all the way through these talks, with clear disparities with racial and ethnic minorities and with social disadvantage. Not surprising, but wonderful that it's now being quantitated properly, so it can be presented to politicians and to public health people. So we move on now to the last of the talks from Nikita from the London School of Economics, which really addresses what we were beginning to talk about earlier on, That is how we gather data on health inequalities. And Nikita is going to talk about reflections from the UK experience. And I hand over now to Nikita.
Thanks, George. And it's really great to follow that wonderful quote from James Baldwin and Maria's amazing data. Hopefully this can start to shed a little bit of, dig a little bit deeper into these issues related to collecting data on minoritized groups and how fraught that is. So today I'm presenting on behalf of both myself and Professor Laura Baer, who has been part of the SAGE Government Advisory Board to the UK coronavirus response, and specifically has worked with the SPI-B group and the ethnicity subgroup directly on these issues, particularly related to increased mortality in Bangladeshi and Pakistani groups. So this is kind of a kind of more anthropological, as we're both anthropologists, and historical perspective on what it is to collect this kind of ethnicity data and how that's played out during the coronavirus response. So just to begin with two really interesting studies that highlight the fact that Europe is anomalous almost in the fact that it doesn't collect ethnicity data, or there's a kind of strong aversion to collection of ethnicity data. For example, by Morning in 2008 indicated that of 141 countries under study, 63% incorporate some form of ethnic immigration. And across Europe, only 5 of 35 countries surveyed collected ethnicity data in the most recent census, which is slightly outdated. I think what's really interesting about the decision to collect or not to collect ethnicity data is that it is deeply embedded in forms of state formation and ideologies of national inclusion that are often embedded themselves in histories of colonialism and migration. And here we can begin from Benedict Anderson's insights on imagined communities, that the census is one of 3 institutions that create a common imagination for its subjects. And that there's a range of reasons why ethnicity data is collected or not collected. For example, the model in the Soviet Union, which was counting to dominate, collectively identifying racialized others, so used for negative and discriminatory purposes, versus not counting in the name of national integration, where a collection of race or ethnicity data is not collected in order not to discriminate. So, for example, as justified by French ideals of laïcité, counting or not counting in the name of multiculturalism, referring to, for example, Latin America's tendency to valorize racial mixing through distinct practices of counting or not counting, and then counting to justify positive action in the pluralist models of places like Canada, the US, the UK, and Australia, where racial enumeration is a tool to fight against discrimination. So we can see like complex histories of policy debate and events that kind of lead to these approaches in the literature. So the value of collecting ethnicity data is clearly, as we've seen through the incredible studies in this workshop, is that we can render visible the unequal impact of things like pandemics or other chronic health problems in order to design targeted interventions to invest in those communities and to adapt care strategies. But the critiques are sometimes that the statistics and the census don't just capture reality, but they create it and are used to blame, to define, and to control communities, where we have a lot of interesting cases of this, particularly in anthropological literature. So just to think a little, to move briefly to the UK and to have a look at the way in which this kind of state building project has been entwined in the census since the late 19th century during the colonial period. We see that in 1841, the question of parents' birth was added to data collected on colonial subjects and has remained in place until the Census Act of 1920, which recommended that race and nationality statistics be collected in Great Britain to understand the needs and circumstances of the population. So things were shifted again in the civil rights kind of period in the 60s and 70s, where special bodies were created to deal with issues of discrimination, social welfare and integration, and a range of kinds of data was collected and interpolated based primarily on the place of birth of a household head. So we see that there's still kind of very straightforward divisions between ethnic groups, particularly in the UK, in the difference between South Asian groups as a block, Black and Afro-Caribbean groups as a block, and white groups as a block, which then came to be disaggregated over the last 20 years of up until the turn of the millennium. We also see that there were a number of key political events, such as the Haringey Affair in 1979, that urged people not to answer the question on race and ethnicity out of fears of being sent home, which have gained resurgence in the last decade around the Windrush scandal, for example, in the UK. How does the UK collect ethnicity data? So the UK collects ethnicity data through primarily the census and three subsets of the census, and they have the institution of the Office of National Statistics, which has done particularly amazing work during the pandemic to try and render visible the impact of inequality that I'll come to in a moment. However, there's really high rates of GP registration in the UK, which mean that there is quite specific data on primary healthcare related to ethnicity and socioeconomic status. Ethnicity is also recorded in hospital episode statistics and collected by governmental organisations such as Public Health England, the National Centre for Research Methods, and through mechanisms in the Economic and Social Science Research Council grant-making programmes. And what do these reveal? So they reveal that in England, people from the Gypsy or Irish traveller communities, the Bangladeshi and Pakistani communities have the poorest outcomes across a range of indicators. While the incidence of cancer is the highest in the white population, rates of infant mortality, cardiovascular disease and diabetes are highest among Black and South Asian groups. We also see that older people from ethnic minority groups experience poorer health outcomes even after controlling social and economic disadvantages, and we see a range of inequalities related to infant mortality. And we see that these inequalities were both exacerbated and rendered new by COVID-19 that we saw so brilliantly in Maria's presentation before. And this data showed that people of Black ethnicity have had the highest diagnosis rate. This was during the first wave data that came out in May 2020, with lowest rates observed in the white British population. And in 25% of patients requiring intensive care support were of Black or Asian background. We've heard a bit about this before, so I'm going to move on, but you can read a bit about this in our case study in the interim report. But what I think is really important for us to present is the fact that this data, particularly in summer 2020, entered into a very, very fraught climate and was, excuse me, and was really a source of fury and distress from minoritized groups themselves, who either did or didn't identify with the data, and this was happening at the same time as the Black Lives Matter protest. So it was a very politicized presentation of data. And at the time, Laura and I in a research group at LSE Anthropology were doing ethnographic research across the UK with minoritized groups. And this revealed really complex emergent folk explanations that were often grounded, sometimes grounded in eugenic arguments. there was a lot of ambivalent attitudes towards the BAME category that was used to kind of group together all of these minority groups, where some identified with it and used it to make claims against the state, and others found it really homogenizing. And there was a really strong counter-narrative that ethnicity wasn't being properly understood in relation to deprivation, and this complex relationship between discrimination and socioeconomic status was not fully being captured in this kind of data. And so a range of mechanisms was set up in order to understand what was happening here, including this by the ethnicity subgroup, which Laura was part of, a range of ESRC COVID-19 grants, mechanisms within Public Health England, and the Racial Disparities Unit in the UK Cabinet Office. But this was met by, so the culmination of the government inquiry into these issues produced a report that actively denied structural racism as a cause of inequality, that was met by fury from communities in the UK, that we were doing further ethnographic research at that period when it was released, and our ethnographic evidence suggested that it was damaging to relations of social cohesion. But at the same time, there have been successes in how that data has rendered visible really deep inequalities in mortality. For example, in the inquiry into Bangladeshi and Pakistani group mortality in the second wave. And you can read this report that Laura Bear led on differential health outcomes among minority ethnic groups that was published in March of this year, that really highlights those really complex intersecting challenges related to disadvantages associated with occupation and household circumstances, barriers to accessing healthcare, the potential influence of policy and practice on COVID-19 health-seeking behaviour, and the real need to invest in the social infrastructures of home, workplace, and community in order to build community resilience against pandemics. So what are the implications of this research? The advantage of collecting ethnicity data during COVID-19 has rendered visible structural inequality and racism, allowing for targeted investment into locally led schemes such as the Community Champions Programme that is burgeoning in the UK, and really successful vaccine uptake programs for minoritized groups. And you can read a little bit about that in our social infrastructures report that I'll pop in the chat after this presentation. But the disadvantage is of collecting ethnicity data is that ethnicity itself is analysed often as the exhaustive range of other factors and cannot be grasped in its complexity, leading to unstable assertions that often cause social distress and divide. To remedy this, there must, Laura and I, have really benefited from undertaking qualitative participatory and ethnographic research to understand this more complex picture and paint its nuance more deeply. So thank you so much. I really appreciate your time, and I'll hand it back over to you, George.
George, you're mute.
Thank you very much, Nikita. Again, the same theme emerging from your talk, but in a much more poignant way, saying that racial estimations must be used as a tool to fight discrimination rather than to highlight discrimination. And then your latter points about the politics of this, of course, are incredibly important. And when you have the data that you're talking about, the question then is to sort out why. And you showed beautifully the potential reasons in your Bangladeshi and Pakistani population of housing and close quarters and so on. So thank you very much for that, Nikita. Well, we've had some really, really fascinating talks this morning. And all really focusing very well on the fact that there is clear a disparity in care for COVID, and that if you extrapolate from this, of course, you would say this is likely to go for other pandemics that we will see, and that's inevitable, and we will have more pandemics. Now, we have some time now for specific questions before we go into the breakout sessions. I wonder if I could just start it off by asking about vaccination, because clearly in all of our countries, vaccination is one of the major ways that we can affect, at least that we hope it can affect, transmission and, of course, mortality. And Giuseppe, I see from your chat you were indicating that you are going to be looking at vaccination uptake in different groups. I wonder if you can tell us how far you've got, or if you're just starting, and how you aim to do this. Over.
Unfortunately, we are just starting to do it. It's of course, the expectation is that being a universal delivery, offer and delivery, it should be an important equalizer into the story of the pandemic. But the story of inequalities in vaccination is usually showing inequalities, opposite inequalities, because there are people, more educated people that are opposing the vaccination in the other cases. But we have not solid data now to comment on the access to vaccination, at least in Italy, yes. by socio-economic position. So I cannot comment more on that.
Well, that will be very interesting to see if its access to vaccination is the challenge, because I think in one of the talks on homelessness, the knowledge of the homeless population about COVID was very good, actually, and the social distancing was remarkably good. So I just wonder if it's going to be access to vaccination, which is the challenge to reach these groups. And I look forward to your data, Giuseppe.
Yeah, in fact, when we looked with more qualitative information, it's the more vulnerable groups were also the least affected by contagious, because I'm thinking to the drug abusers or to mental health people, because they are naturally socially distanced. So yes. It's they don't need to be, because they are usually excluded from the contacts. So we have observed really a better profile of risk of infection in these groups. But this was before the vaccination. So of course some groups may still be more difficult to be reached by vaccination, but in many cases there have been organized some low threshold interventions with mobile units and so on to reach vaccination, both testing and vaccination among very elusive population like the homeless. And this could be helpful and effective.
Thank you, Giuseppe. Ilse, I think you had a comment to make from your chat.
Not exactly a comment. I'm just posting some things on that can be interesting in relation to the topic that's were mentioned.
Okay, would you like to tell us about that, or we just look at
but both on access to ethnic data, as I put in the chat, that this has been something that we really struggled with in Belgium also, of course, related to the past also, and did not get any progress on it still so far, or despite my pleading for it, and not only me, also other academics in the past 20 years already. Also recently it came up. I think if we could get a kind of recommendation out of Periscope on that is supported by that large group of academics, we could also get maybe some input from that on the Swedish case, where they, with the national registers, I think have great data on access to healthcare and healthcare issues. That's one point. And second, on access to vaccination, EPIDEMICS, which is a wide European consortium, or a lobby organization on undocumented migrants based in Brussels, has great updates all the time on access to healthcare, but also access on vaccinations for undocumented people. So in relation to status, including asylum status.
Thank you. So is that PCOM data published?
Yes, yeah, they do it regularly, but just online, open access, most of maps.
Accumulative data,
yeah.
Now, another thing which we are seeing in the UK, and it was on the BBC News this morning, actually, in a very, very good way, that is the occupational aspects of transmission. And that people, for example, bus drivers they were talking about, who kept going during the early stages of the epidemic, there were many deaths of bus drivers over the norm that we were seeing, and insufficient protection was given to them at the beginning, and it has caught up now. But there were occupational deaths in lower income groups needed by society to keep it going. I don't know if anybody else has got any other examples where bus drivers were the one we had in the UK. Shop workers.
Of course, I forgot to say that the Italian data that I show were excluding the healthcare workers, because if you include the healthcare workers in the analysis by education, by social disadvantage, of course, you don't find anything, any inequalities, because the health workers were the one more hit by contagious, by infections, and also by severe health consequences, and they are mostly graduated. So you have to distinguish the two parts if you want to monitor health inequalities, at least in Italy. If you include the health workers, you don't find any inequalities, any social inequalities in COVID story.
Interesting.
If I may, oh, sorry, somebody raised their hand. I'll raise my hand.
Yes, Maria.
Yes, I just wanted to say that I first of all, I'm glad I have a camera. I just mentioned some data on socio or ethnic disparities with regard to who was in an essential job during the epidemic and who wasn't. And we also have data from another large study in France, which I didn't mention. The study is called EPICOV, and it's a national sample of 100,000 people selected at random in the population. And that study shows that people who work in essential jobs, so it's bus drivers, healthcare workers, but also people who work in cleaning, in security, cashiers in shops, etc., were more likely to actually be infected with COVID-19, and those people happen to be more often belong to minority groups, either immigrant or from the French Caribbean.
Good, thank you very much, Maria. Now, Nikita, you still there? The health disparities in the Bangladeshi and the Pakistani population were very apparent from your data, not just for COVID, and you had that very clear list of potential reasons for that: overcrowding, housing, and so on. Would you like to add anything extra to that? Over to Nikita.
Yeah, I just wanted to, as you were saying about the bus drivers, I just wanted to say, that basically what we've been looking at as a research group are the kind of flow-on effects through kinship networks of something like an exposing occupation. So in, for instance, the Bangladeshi and Pakistani populations in Tower Hamlets in East London, you have often a family business or small or medium enterprise that is run by a whole family, that is like something like a corner shop or a convenience store that doesn't close in the pandemic. It's an essential service, you know, and often there's an inability to go and get tested or to isolate due to the need to keep up that livelihood for a whole family. You know, that SME is then linked to an overcrowded housing situation where there's a large family or multi-generational family living there, that increases transmission right through the household. And we saw this kind of again and again in communities in Leicester as well, linked to the garment factories. But then also something that I wanted to indicate that Laura's spoken about in that report that I mentioned and that we've written about extensively in our social infrastructures report is the way in which that kind of leads to a stigmatization of those populations, these kind of maps around the location of transmission in particular areas that are known to be Bangladeshi or Pakistani, for example, then leads to a stigma against the whole group and avoidance of those populations. So we pick that up a lot in our ethnographic research and our survey research. So yeah, again, just these kind of very tense and kind of nuanced flow-on effects of rendering visible that inequality and the need to kind of map out those kind of chains of transmission across kinship networks as they interlink with places of work.
Yes, thank you, Nikita. You mentioned that racial enumerations for USA, Canada, and the UK can be used as a very positive tool because you identify differences and then you identify the reasons and hopefully make a change. The converse of that, of course, is that in some countries, these ethnic differences are used against those ethnic groups. Do you have evidence for that? And would you like to mention any evidence that you have? Because that's a real indictment, actually.
Yeah, so for example, we've done quite a bit of work with local public health teams and local government in Leicester. And in Leicester, there was increased transmission around COVID-19 in South Asian groups, particularly migrant or precarious workers in garment factories. And when that data was presented, it was used by the kind of media to then blame those groups for transmission and to blame those garment factories for being a kind of for being informal and illegal and not stopping and not being adherent. And so that's why things like what Simon spoke about as the kind of high levels of knowledge and adherence in vulnerable groups is really important to highlight, because you see that this isn't necessarily a problem of non-adherence or compliance, but it's actually a much more complex set of concerns related to stigma and blame.
Yes, thank you. I should point out to having made a mistake between the Netherlands and Belgium, that Leicester is a city in the Midlands of the UK, quite a small city, but a high Asian British population. And in addition to what you've been telling us, Nikita, examination revealed that these groups working in the garment factories were paid very, very poorly and well under the national lowest wage possible. So, there was clear discrimination throughout this society. And I just hope that the data that is being collected now can be used in a positive way to fight against discrimination, but also, of course, as a physician, to help this population in terms of their health. And you mentioned the other disparities, infant mortality, higher in these groups and so on. These things must be addressed. Without the data, you don't know what's happening. So it's a very important step to collect accurate data. Good. Now, are there any other questions before we move on to the workshops? If we just look at the chats, does anyone have any point they'd like to raise from the chats, or any new specific questions before we break into the well, we'll have a coffee break first of all, of course, and then we'll come back for the breakouts. No, well, I see no extra hands. Oh yes, we have a hand there. Yes.
Hi, George. Just to the point that the point that Ulrich makes, and I very much agree with it, is access to information and differential access to information is itself an inequality. It's something that we've looked at, particularly in the context of cancer, and actually access to information underpins the first right that we've identified for cancer patients under the European Code of Cancer Practice, and I've put the link in there in the chat as well. But just I'd very much agree, because that's one of the things in terms of not having, sort of adapted, for example, information, and making sure there are different pathways in which information can be provided, particularly to underserved communities.
Good, thank you, Mark. That's very important. I mean, looking at the data in the UK, the access to cancer treatment and the access to orthopedic surgery is absolutely disseminated, is absolutely decimated, rather. And what we're seeing now, estimates of 5-year extensions for orthopedic surgery. And of course, for cancer, it is very important to have rapid screening and rapid access to cancer treatments. I certainly hope that this is going to be looked at with clarity. And we know from Giuseppe's work that disadvantaged groups are even worse off than other people. And we're seeing in the UK now, access to private healthcare is ascending. And I somebody who's worked in the health service for many years in the UK, I find that quite disturbing, because that will accentuate
the inequalities.
In inequalities.
Yeah, no, absolutely.
Good. Well, thanks to all of the speakers and to the very, very fine chats that have come up. Just to say, this is being recorded, of course, and you will all get recordings. So we should break with Alfred telling us that actually these migrant groups are no different from us. They have mobile phones, they do well, and they can get information from these. Very interesting that that is the case, and we could perhaps use that as a mode of communication. So the workout groups now have finished, and we move on to the plenary discussion. And Giuseppe, who introduced the meeting with his very clear talk with those lovely data, is going to be the moderator for this. So I hand over to Giuseppe.
Thank you, George. I'm wondering why to change such a brilliant chairperson and with another moderator that is not so brilliant as you.
Giuseppe, you gave the most wonderful talk this morning.
Anyway, I think that we had an interesting discussion in the groups, and the main issue was to start to try to understand from the reading of the report if there were important missing issues or controversial issues to be discussed more. and how to solve the measurability problems on many indicators that are not yet available at large in Europe. These are two main questions that have been discussed in the group I was attending. But I'm wondering if the groups are able to report the main result of the discussion briefly now. Can we move to group one, or who wants to start to report
Yeah, I'm fine with starting, Giuseppe.
Okay.
We were chairing, Eva and me were chairing the group one on health inequalities. We planned to share the Miro board. I don't know if that is possible that we use that one. Laura, is that fine, or that we use,
Sure.
do it that way?
Sure. I stopped sharing screen. So if you want to do it, or
Yeah.
feel free. Thank you.
So Eva will try to share, and we shortly introduce that.
You can see your face, Isa. Yeah. But we can't see your slide.
Eva is trying to share.
I'm trying to share it. Just a second.
We can see you now, Eva.
And then share.
Don't worry if oh, we've got it
Here
now.
we are. Here we are.
Can you see it?
Yeah, but you should broaden it that we can see the green ones. So if you just make the green ones larger, yeah, the other way around.
Yeah.
Still larger, yeah. It's difficult to read like this.
Yeah.
Yeah, more or less we are getting there.
I don't know why it's so
Small, yeah.
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 I'm gonna zoom in a little bit more.
Yeah, but that's fine, I think. If
Yeah.
you just can explain a bit, Eva.
Yeah.
Yeah.
So first of all, we mentioned again the information part, that it is important to maybe focus a little bit more on that even, because stuff like access, the right giving everyone access to information. What about fake information, misinformation, and how healthcare workers deal with that? We are also planning to focus on that a little bit more in work package 11. But still, I think a lot of health inequalities are related to misinformation and information access. So that was mentioned in our discussion. Also, reaching the right people with relevant info. Not all info is relevant for everyone. So I think that is important as well. Ilse gave an example of how doctors use intercultural mediators during their sessions, or I'm not
Consultations.
Consultations. Yes. So that's a good example of how to work with this, and how healthcare workers can maybe focus on not on giving the right information. The next one, and the next thing that was mentioned is a sort of inequalities register, where is focused on what are the inequalities, what are the social determinants for these inequalities, also the differences between these pre-COVID determinants of inequalities and the post-COVID determinants. How can we use this sort of register for targeted interventions to target the correct people? An example for this was maybe a list the particular things that COVID has exposed people to, in order to get a clear view on what are the inequalities exactly, and what is the result of this. More specifically, gender inequalities was briefly mentioned, that there is not a lot of focus on that, but of course there's a combination of many different factors that come into play. Gender inequalities are different when it comes to different categories of age, or social social statuses. So again, it is important. This goes a little bit back to the inequalities register, I think, to define specifics of the groups. What are the determinants, and how can we get a clear view on what are these inequalities, and how can we use this to target and to do targeted interventions. And then last, it was briefly mentioned that we, how can we use all this information we have in this report to learn from this pandemic and can deal with other crises, not only human crises, but also non-human crises. And it's also mentioned that other work packages in Periscope are already working on it, but I think the report is a good basis for this. So yeah, I think that was everything.
Yep, I think that was it. Over to you, Giuseppe.
Thank you, Eva. Thank you, Ilse. Let's move to the group 2 and breakout 2. And so we will make discussion at the end.
Yes, fantastic. I think that's the group that focused on mental health inequalities, which very much overlaps also with the discussion from the first group. And there were, you know, I think with every group, there wasn't enough time to discuss everything, but I'll try my best to summarize some of the points that were made. In this breakout room, we looked at and discussed some of the indicators around inequalities and especially looking at data. We discussed kind of the challenges around how a lack of data also kind of puts strain and allows us to lean more on information in regards to anecdotal information and data in that sense. And also understanding a bit more about the differences between how data is disaggregated data, in particular in countries where it is gathered, how that works and how that could be applied at different member states. We also talked about how you know, vulnerable groups in some sense have also been described as being really resilient. So looking a bit more at, whilst that may have been the case, what role has community-based structures had on supporting and ensuring mental health support in particular, and in any case looking at whether funding and additional support can be provided in that sense. There was a bit of discussion also about the lack of information around how the difference in mental health support prior to COVID and during COVID, and the need for there to be a bit more clarity on that so we can compare and contrast. We also discussed a little bit about, for the report itself, because again, a lot of information is anecdotal, kind of having a bit more clarity also within how we provided data and information and included it in the interim report, and how we did that in a systematic way, so looking at more the methodological sense. And we also talked a bit about how we may need to look a bit more at impact, mental health impacts, and also looking at suicide in a bit more detail, looking at data around suicide, and maybe other gaps as well. I know, Claudia, you didn't get a chance to have too much of an intervention, so if you want, feel free to jump in. But from the Restory project, Claudia mentioned how they looked and found information in regards to the intersections between mental health and also gender as well, and how that may need to come out a bit more in the report itself. And also there were a bit of discussion around the social determinants around mental health problems, and how we could also highlight and bring out that in the report, and how we categorized and kind of determined what to include and what to leave out. So these were some of the discussions, but we also talked a bit about the lack of disaggregated data, distrust within communities, and how that impacts mental health support and care, and actually what we mean when we're talking about tailored services for different groups. So in a nutshell, these are some of the things I've discussed, but if anyone from the group wants to jump in, maybe if I miss a point, feel free to.
Fatima, thank you very much. Unfortunately, we have not time to move further, so we have to move to the other group on access to healthcare.
Thanks, Giuseppe. I'll report back from our brilliant discussion. So there were a couple of key topics around access to healthcare that we discussed, and a few areas where we could add detail, particularly in the report. I think one of the most important was looking more deeply into ageism and age-based discrimination in the report as a key health inequality that has been exacerbated by the social distancing regulations in the pandemic, and is linked to all sorts of issues related to digital literacy, and also an extension of that to the work of caregivers, and particularly unpaid caregivers who've often had to give up significant opportunities and employment in order to take care of their elderly or disabled or vulnerable dependents. So that was one key issue that I think perhaps we could take back and add more deeply into the report. We also discussed, Gabriella brought up the issue of literacy, and we discussed the ways in which literacy needs to be mapped out, the different forms of literacy, as in being able to read a language versus being able to access the right spoken language, versus digital literacy, versus having a technology device in order to access health information or services. So a real need to understand those pathways in literacy and map out that kind of terrain that's been rendered new in the COVID-19 pandemic. Lorenzo brought up the really important point around privatization of both healthcare and social care, and really trying to understand the impact of privatization during the pandemic, as it's happened, for example, in the UK, and prior to the pandemic. And he's indicated some really interesting papers on that. We also, let me see, have I missed anything out? We also looked at the need to really develop better models for working with communities to understand their needs in order to improve trust and decrease senses of isolation from the healthcare system and barriers to accessing the healthcare system. And that in turn linked to the issue of stigma and the stigmatization of risk groups that were more severely affected, being a driver of lack of access to health inequality. So those are the kind of 5 key topics that we discussed in our group. Alma, did I miss anything, or anybody from our group?
Thank you, Nikita. Excellent. Last group on vaccination.
Right, so we talked about inequalities with regard to vaccination. I will let Simon share his screen with the Miro notes. Okay, Simon, do you want to go ahead and discuss?
We have it.
Do you want me to discuss the main topics, or do you want to comment on it?
Summarize, yeah, that'd be great.
Okay, so I hope I'm going to be faithful to what's been discussed. So it was a very interesting discussion where, as in other groups who mention gender inequalities with the higher hesitancy of women that was observed and need to be further investigated. We also had questions on age distribution of the vaccine hesitancy as in order to be really representative of similar age group in the general population, and make sure that the assessed risk factors really corresponds or to a similar reference group. The concern of the measures on the actual access to vaccination was raised as an important matter of concern, not only the hesitancy, but the actual access. An example was mentioned about the vaccination of migrants in France for travel motives, as similarly to other countries, the sanitary pass has been installed. And so vaccination is not necessarily the easiest thing to travel. We discussed also the access to information and in all its complexity. So accessing the information, it's been mentioned that they have the similar access, similar knowledge to the general population, but then I've added the trust toward authorities. So the attitude towards this knowledge and health literacy, how individuals, I don't know how to say, the way they understand, the ways they use, they have critical assessment on these informations. And finally, probably one of the major things on this discussion, the multifactoriality of vaccine access and hesitancy. So it's there's a lot of dimensions overlapping, like the gender, age distribution, the ethnic, and the homeless. There's a lot of overlap in these populations. So we really need to move forward, distinguishing, disentangling the specific effects of all these risk factors to better address them.
Thank you, Simon. Simone, I think that we have not so much time to develop general discussion, because in 4 minutes I have to give the floor to George for the conclusion. So there is time for one hot question before the end of this very interesting contributions from the 4 groups. Are you still excited for a last question? Enough? Otherwise, I can give a last comment from myself, which is related to the fact that to the positive aspects of this pandemic. I think that one positive aspect is the fact that that for the first time, health in all policies has become not only a general statement and recommendation, but something very concrete. Indeed, every day, everybody was submitted to the decision of what to do in terms of going to school, going to work, going to social activities, etc., depending on the risk that was creating to somebody else. And to the level of spread of the infection and of the health consequences. So for the first time, the health outcome was the main criterion for deciding what to do in the society, both at the individual level and at the societal level, at the political level. This is exactly health in all policies, health equity in all policies, if you also add the equity lens in this thinking. And this is an asset that we should not lose. We should build on it. It's an important aspect of the disseminated culture due to the pandemic that we should try to exploit to make the way to weight more the health outcomes and the equality in health outcomes. It is not given for granted, because there is a tendency to remove from these aspects when the pandemic will decrease. It's an investment that we can try to underline in this in your final reporting, because it could be very helpful. And to do it, it's absolutely important to learn to wear the equity lens wherever and whenever possible, and not only related to the specific vulnerable groups, but to any kind of a disadvantage that could be important in the pathway of a disease and of a mental health problem. and to learn how to wear equity lens in the everyday life and decision making, it's a very important achievement. In fact, when we have analyzing the 18 countries in our survey in Europe, the ability to take seriously practice the response to health inequalities in the pandemic, we recognize that the countries that we already have studied as for being more able in terms of structure and processes and mechanism of governance for health inequalities were also the ones that have been able to do the best in terms of tackling health inequalities in the COVID pandemic. So it's a long process, this one, of improving our ability on governance of health inequalities. But the main brick to be able to use for building this building of a governance for health inequalities is the equity lens, and we have to learn to wear them wherever and whenever possible. And so that's my last word.
Giuseppe, thank you very much. You started us off with a magnificent talk, and you finished with some beautiful conclusions from the event today. Thank you. And I would just like to make one or two last comments. The first thing to say is what a privilege we all have. We have food, we have education, we have friends, we have the ability to have meetings like this. And that to me says that we are a very privileged group. And it's a great comfort to me to see that all of us from this position of privilege are concerned about our fellow human beings who are disadvantaged. And they're disadvantaged in all ways. And as Giuseppe has pointed out to us, and many of the other speakers have, that the COVID pandemic has really accentuated this difference between a privileged group and a group which is underprivileged and is more susceptible and is more susceptible to the severe disadvantage in pandemic, which goes through to death, of course, not just being ill. So it is great for me to see the commitment of all of us today from a privileged position to want to examine what has been happening and to identify areas that we could make a difference in for those who are disadvantaged. And that gives me hope. Now, most of my career, of course, has been in a teaching hospital setting and doing really quite advanced medicine to help people. What I've realized in my advancing age is that the health of an individual governs the health of the population, and that public health is every bit as important as the cardiac surgery and the insertion of new prostheses. It is crucial to the health of a community. And I see that with the epidemiology we've been discussing today, we've identified areas from COVID which are potentially amenable to change. Now, only once, I think, the word politics has been mentioned. And of course, we have to convince our political, I would say, I'd use the word advisedly, masters, our political governors, that's perhaps a better way to do it, that by increasing the health in general terms of the public, we are increasing the health of everyone in society. And as in the group, the workshop I was in today, Professor Spiro from Paris said very clearly, these disadvantaged groups that we talk about actually are quite sophisticated. They are disadvantaged in the practical sense of warmth and heat and food and nutrition and so on, and access to medical care. And we have to do something about that. And our politicians need to be aware of this, that really quite simple things can be done. We haven't talked about children in these conditions as well, because their education, their health, and their future is the future of the population as well. So that's another aspect that we will have to be looking at. So in summary, I would just say thank you to all of you for giving such wonderful presentations. I have learned a lot. And as I said at the beginning of this closure, what a privilege it is to listen and to be part of a group like this, committed to making a difference. So with that, I think I should just say thank you to everyone. Thank you to the FEAM staff, to Emma, Ruben, Laure, and Patrick for enabling this to happen. Because if the mechanics fail, the whole thing looks really quite difficult. And thank you to all of you. I look forward to meeting again in the future when we can continue our discussion. So goodbye, everyone, and thank you.
Thank you, George.